that we can use to make our decisions, and that's cognitive intelligence. So when you think about that, one thing we have to be careful is what's coming out of those predictions is only as good as what goes in. They can have bias, they can have incorrect information. We have to always remember to put our thoughts, our spin, our intuition, our experience into what we're getting in predictive analytics. And then diagnostic tools. So we talked about all the x-rays and everything, but they can also take, let's say you have just a CBC done. They can compare that with CBCs across millions of people because they have that in their database, and they can predict things that could be happening in your future.
Which have been studied. Men often do not seek care. One barrier is work constraints. Several countries that we visited, the clinic hours are usually 8 to like 4. Sometimes we try to make it a little later to accommodate men, but 8 to 4 because the men are at work. So one barrier is work constraints. Many men cannot attend because clinic hours overlap with their jobs. This has been documented in centers like Malawi and among migrant workers in India. Their services are offered only in the morning. Where a second barrier comes from cultural norms. In many places, clinics are seen as spaces for women and children. Masculinity expectations discourage men from appearing vulnerable or asking for help. The third barrier involves providing gender.
And how long they want to stay where they are. The other thing though when you do this is that if they say as one of their objectives, I want to attend this conference, as a nursing leader, what do you need to do then? Find the money to help fund it, whether it's fully or partially. And the other piece to that is making sure that you can give them the time off. There's nothing worse than being on PTO and normally would have worked and getting that text message from one of your coworkers like, oh friend, we're short, can you come in? So making sure that you have the resources to truly support that growth. Another really important piece, Dr. Geiger kind of talked all about this, is that mentorship and peer support.
So we were like, well, we like money. How can we save money? How can we, affect that bottom line? And we decided to go the route of learning a little bit more about what we could do to help impact the oral pressure injuries. So knee deep in a lot of this research, we really had to dig to find a very amazing and vetted tool, but highly underutilized. And it's called the MROMPUS tool. And it stands for the Modified Reaper Oral Mucosa Pressure Injury Scale. And even though it's a super long title, it's just 3 simple steps of assessment, which, as we're all aware in working with our nurses, easy is what gets them to buy into something, right? And ease of use, ease of documentation, all of those things. So how could we make it easy to be able to make this a practice that's continually utilized?
It's important to mention that we had a little bit of turf war with the nurses and the RTs, and so that was interesting to try and navigate, because RTs are like, well, I manage the tube, and nurses are skin. So who's managing the skin around the tube? Very often you end up with like a little bit of territory. So it actually became a very good project in having them work together, truly as an interdisciplinary team. If we're moving the tube, are you in there and assessing around the area? RTs had nowhere to document, and if you didn't run into the nurse, if the nurse was busy doing something else, where would you put your information? Because they're not trained to assess skin. So it did really become a good interdisciplinary tool, a point of conversation, and also the education piece at the start of it helped us to really bring to the fore how often their policy was that you should be doing mouth care. How often do we reposition the ET tube during the day or during the 12-hour shift? So it was very interesting, even just from the get-go, and it opened up a lot of conversation among RT and nurses, and we'll talk a little bit more about what we discovered as we moved.
The complex we prepared is called the FICO sphere. I don't know if there is here, I think no, but the message is to have a complex of nutraceuticals that have antioxidant and anti-inflammatory properties. Sometimes in the past Serenor-Repens was used successfully and is still used. But in this complex we don't use Serenor-Repens, and we use phycocyanin, palmitoethanolamide, PEA, and selenium.
Nurse education now, and now when we built this model, it's first in first place for the nursing, but now it's all higher education for this our project or the education. Now we because it's been a success story. Our students have learned the language. Finnish is not difficult, it's different, and in the Nordic countries, other like Sweden, Norway, they and Iceland, they share the same language family, but we're different, which makes it.
So it's always that high stress environment, and then you wonder why there's a lot of turnover. And that's one of the reasons why. So keeping them satisfied and keeping them happy as residents in the facility, well, if you're the person that's in charge of doing that, but you're also in charge of infection prevention, what do you think is coming first on your list for the day? They have to choose, and they choose to keep the residents happy, of course, right? But infection prevention gets pushed to the side. So historically, no emphasis has been put on the need for dedicated infection preventionists. I work in a hospital. What does that have to do with me, you say? Right? All these people have these big hospital systems. You work at different facilities, acute care. I'm hearing we were talking about, right? So why does that matter to me? Well, guess what?
United States, baby-friendly designation is the gold standard in maternity care. Baby-friendly recognizes maternity facilities that are creative and optimal environment, for feeding the infant and for mother-baby bonding. So what is baby-friendly all about? Well, there's 10 steps to being designated baby-friendly if you know about the certification. But overall, it supports moms to initiate and maintain breastfeeding and manage common difficulties. It supports moms to recognize and respond to infants' cues and feedings, and we coordinate discharge so that the parents and their infants have timely access to ongoing support and care. So with our program, our virtual lactation program, when they get to the hospital, they understand what's going to be happening, what questions they might want to have, or questions they might want to ask, so they're more educated when they get to the hospital. But a lot of times we see our moms and babies after delivery. We try to get to them as soon as we can after they're discharged from the hospital, because we all know for new parents, it really gets real after you're discharged, right? 2 to 3 days after delivery, you're like, oh my goodness, I have so many questions. I didn't know it was going to be like this. And we're here to support them. So we try to get to them as soon as we can after delivery. So how did we get here? How did this program even begin? This program is new to Northwell Health, relatively new.
If you're part of Sigma, International Nursing Society, I was just able, just this week, published a course on mentorship. And it's really about the variability of use of mentorship programs. Because, oh my goodness, there's so many things. You could use it for norming. You could use it for leadership tools, for training, for onboarding, for cross-training. So making sure that you actually have a solid mentorship program would really help support their growth. And it could really stabilize some of the challenges that you're having. It could cause some norming. And then continuity of care. It really covers continuity of care as well. So reciprocal mentorship programs, both mentors and mentees really kind of learn how to grow together. I created a mentorship program when
My presentation will cover the following outlines. Underweight affects 9.7% of women globally, with a higher prevalence of 20 to 25% in low and middle income countries, especially among women of reproductive age. In low and middle income countries, many women, particularly adolescents and young women, are nutritionally vulnerable and don't consume enough healthy and nutrient-rich foods.